So I'm going to pick up on some of the things that Sam talked about in the guidelines and also what Yoni just talked about with DVT prophylaxis. So we'll start with a couple of questions. If you get out your response thingies. So which of the following is not a recommended component of standard ERAS protocol? Intraoperative goal-directed fluid administration, avoid postoperative nasogastric intubation, intravenous PCA for pain control, postoperative gum chewing, or auditing of protocol compliance and outcome. That's good. We want to, of course, avoid systemic narcotic use, so we try to avoid the PCA. So next question, and this is, I think there are only two. So a 72-year-old female is preparing for radical cystectomy and ileal conduit. Which of the following is not part of the instruction package for optimal GI tract management? Number one, preoperative mechanical bowel prep before cystectomy conduit. Number two, preoperative oral carbohydrate loading. Number three, clear fluids recommended up until 2 hours before induction of general anesthesia. Number four, post-op nausea vomiting prophylaxis. And number five, early oral nutrition starting on the day of surgery. So which one is not part of the information package? That's pretty good, yeah. So we want to, the evidence would suggest that we don't need to do a mechanical bowel prep anymore before cystectomy and conduit. So we'll get right into the talk. These are some disclosures. I'll highlight Merck here because I have worked with Merck Canada on bringing alvimopan into Canada, which is not yet on the market. So I'm going to start just with, I'm going to go over what is ERAS, and then I'm going to talk about some of the individual elements of an ERAS protocol and where the evidence is, and then I'll finish off just showing overall the evidence of any given ERAS protocol in the cystectomy population. So the ERAS protocols go back to so-called fast-tracked surgery pathways back in the 90s, so it's not that old really. It comes primarily from Scandinavia, from Denmark, Sweden, and also a lot from the UK. And the idea was that if you standardized perioperative care before, during, and after surgery, that you could reduce the stress on the patient and thereby reduce the morbidity and enhance the recovery. You would maintain patient physiology as best as possible to hasten recovery, and you would hopefully shorten the hospital stay in the process. The idea was to make it evidence-based and to engage all parties involved in the patient care. This evolved into ERAS, Enhanced Recovery After Surgery. There's an ERAS study group, which is now the ERAS Society. And the first protocol that they put out was for colorectal surgery in 2005. And a lot of what we do in the cystectomy population is based on colorectal surgery and other major pelvic surgery, abdominal and pelvic surgery. So why ERAS in the context of radical cystectomy? You know, this is something that we might not consider, for example, in the context of a partial nephrectomy or other diseases or surgeries. But for cystectomy, it really makes a lot of sense. GI complications are a big part of our postoperative management of these patients, and they cause a lot of concerns, morbidity, and cost. They also affect quality of life. ERAS protocols in the other disease sites are able to decrease these complications and facilitate recovery, so it makes sense that they should work also in the cystectomy population. And in the cystectomy setting, it looks like minimally invasive surgery doesn't have as big an impact as it might in other settings, so we really need to rely on better perioperative management and not just a switch to laparoscopy or robotics. Sam Chang at Vanderbilt and Raj Pruthi at UNC have been some of the early adopters of fast-track perioperative care plans for radical prostatectomy going back more than 10 years at this point, with various pre-op, intra-op, and post-op parameters that I will come to. If you look at the core ERAS principles that the ERAS Society puts out, there are 20 individual items on this slide that you can roughly divide into in the same pre-op, post-op, intra-op. And the evidence for any given one may not be that solid, but together we would consider this the optimal management of these patients. And we want to remember that the patient, him or herself, always has to be in the foreground and has to be involved in all stages of this protocol. Also key to highlight is the fact that it really requires multidisciplinary engagement. It's not just up to the urologist or the surgeon. You need the nurses, pre-op nurses, intra-op nurses, and up on the floor post-op, the stoma therapists, the physiotherapists, the anesthetists, of course, are critical. It involves a lot of different parties, and ultimately to institute or implement a successful ERAS protocol in your hospital, you will need buy-in from the administration to get all these parties together to make it happen. Also important to highlight is that it's an iterative process that needs to be audited regularly to make sure that compliance is happening, to see where the issues are, and potentially update the protocol as the evidence evolves. So what is evidence for individual ERAS components? Well, the ERAS Society put out the summary document, a guideline for cystectomy ERAS back in 2013. And a lot of the evidence is really from the colorectal surgery domain, and they rate their recommendations simply as strong or weak levels of evidence. There's a list here. These are 7 different parameters that are considered important in the pre-op setting. Some of these things will be very familiar with you. I mean, the first one, counseling education is an important part of it. Medical optimization, of course, is something that we take for granted these days. Bowel prep can be omitted. I think that's important, but most of us have advanced to that. Preoperative oral carbohydrate loading, I'll show you a little bit of data on that. I think that's something that probably few centers are doing, but the evidence is fairly compelling. And then there are other things in there as well. So if we look at the bowel prep, again, it's been standard of care for colorectal surgery for a long time not to do a bowel prep. And there are only a couple of studies in the cystectomy patient population that are relatively low-quality studies, but they reinforce that it's not important to do a bowel prep and you're not taking a risk by not doing it. The first study was only 62 patients. They had a 3-day standard bowel prep versus just going NPO 8 hours before surgery, and there was no difference in morbidity or length of stay. A second study with 86 patients, again, a standard bowel prep versus no bowel prep, and there's really no difference. So these studies are both highlighting the fact that it's not dangerous not to do a bowel prep, but there's some evidence that it might actually be beneficial to avoid the bowel prep, that it's better for bowel health and better for bowel recovery. So the ERAS Society clearly recommends not to do a bowel prep. The carbo loading and lack of fasting pre-op, I think this has it's taken our anesthesia colleagues a while to warm up to this idea, and I think if you introduce it in your hospital, they really need to take a look at the evidence and convince themselves. But there's this meta-analysis, which is already several years old. This is from 2013. It looked at 21 different studies of quite a variety of different surgeries, not just major abdominal surgeries, but also other things like thyroid and orthopedic surgery. And there are about 700 patients who had preoperative carbo loading compared to 900 patients who did not. They were fasted in the usual manner, or some of them even had a placebo, basically water loading. There's no difference in length of stay between the groups as a whole, but there was a decreased length of stay for the patients with major abdominal surgery who had the preoperative carbo loading. There was no aspiration pneumonitis, aspiration pneumonitis, and there was no increase in complications. And those are both important points because you would worry, of course, that you might have complications from having stomach contents at the time of induction of anesthesia. So it's considered very safe, and it's considered potentially beneficial, again, for postoperative bowel recovery. This, I'm just going to jump over. Thromboembolic prophylaxis is obviously an important part of ERAS, but I think Yoni has really discussed that in detail. For intraoperative parameters here, we're again more reliant on our anesthesia colleagues. The first point on this list is thoracic epidural. And it's interesting, the group at USC have been big proponents of ERAS and have published a lot on ERAS, and they actually consider lack of epidural as a key component of their ERAS protocol because they use a regional block with a TAP block or a rectus sheath catheter. So there are alternatives. The idea with the epidural is that you're avoiding systemic narcotics, but of course if you're putting narcotics into your epidural, you may end up with the same problem. Minimally invasive approach is important in a lot of surgeries, maybe not as important for cystectomy. If it is, it's just one element in the ERAS protocol, and it's not the key element by any means. Another thing on this list is this goal-directed fluid therapy. And in our protocol in Vancouver, it's been the one issue, or the one component that we've had the most difficulties with as far as compliance. There's too many anesthetists, each one does it a little bit differently, and ultimately they're not doing the fluid resuscitation intraoperatively based on objective measures. Postoperatively, these are things that, again, fall more in our domain as the surgeons. We certainly want to avoid the postoperative NG tube. I'll show you some data on that. There are measures to prevent ileus, including gum chewing, and there is some data which I'll show you. Early mobilization is, I think, a no-brainer these days. And then we like to start nutrition early, and I think this is one thing in the cystectomy population that may differ from the colorectal population. I think it is more difficult to start feeding patients earlier. They're more likely to end up with nausea and vomiting if you give them too much too soon. So the NG tube, I think that most of us have abandoned this now a long time ago. I know when I was a resident, it was still very popular, but things have changed. This was a Cochrane review of 37 prospective randomized trials in over 5,000 patients, not necessarily including any cystectomy patients, but it compared early NG tube removal within 24 hours, and this includes patients who had no NG after surgery, versus delayed NG removal. It was only open surgery. It could be elective or emergent. And there are a lot of forest plots in this review paper, but I've summarized them just here. There are clearly some harms with an NG tube, with leaving it in after surgery. So the time to flatus across these studies was clearly increased. There were more pulmonary complications with an NG tube, and the hospital stay was longer. There was no difference with respect to wound infection, anastomotic leak, or incisional hernia. The benefit of leaving the NG tube in, there was less vomiting. But overall, the risks clearly outweigh the benefit, and post-cystectomy patients should not have an NG tube. The authors concluded routine NG decompression does not accomplish any of its intended goals, and so should be abandoned in favor of selective use of NG tube. Gum chewing is very simple. Our biggest obstacle to gum chewing is that the hospital doesn't provide it, so the patients have to get it themselves. But it's so easy to do. There are two trials that have looked at this. One in Asia, I think it was in Korea, and the UNC group has also looked at it. One of the trials was with a ERAS type protocol. The other was basically non-ERAS, so the gum chewing was the only difference. And patients had quicker return of flatus and first bowel movement, no difference in morbidity and length of stay, and I don't think we can expect too much from gum chewing, but it's so easy to do, and there might be a quality of life benefit with the time to flatus and BM. Now, alvimopan has not entered into the ERAS Society protocol because it's newer than the protocol, but it, of course, has also become an important component in the US and wherever it's approved. And this is a phase 3 trial in a sort of ERAS protocol. So this is multi-centers across the US. Cheryl Lee led it from Michigan. I know USC and MD Anderson were in it. I'm not sure if Mike and Sam, if you guys were part of it as well, yeah. And so there were components of ERAS, but it wasn't a complete ERAS protocol, and then it was either patients are randomized to alvimopan or placebo. And there's some very important endpoints here that were improved with the alvimopan. So time to recovery of bowel function, essentially time to discharge, hospital stay, were all improved. And even the postoperative ileus-related morbidity was improved. It costs approximately $100 a day. And it's given on the day of surgery and once daily as long as the patient's in the hospital. So if the patient's in the hospital approximately 7 days, it's approximately 7, or here in the study, it was $880. The cost analysis showed that the use, this additional cost is more than compensated by cost savings due to decreased complications, particularly around the postoperative ileus. So what about if we put this all together in actual ERAS protocols? What does the evidence tell us about ERAS versus no ERAS with radical cystectomy? There are several reports in the literature. These are papers that came out prior to 2015 and were summarized in this 2016 paper. And the big criticism is sort of threefold. First of all, a lot of it's based on colorectal surgery evidence, as I suggested. Second of all, you can see in the last column the number of ERAS items. Everyone's doing it a little bit differently. It's fairly arbitrary and inconsistent. And then the third thing is there's a real lack of prospective data. And that hasn't really changed, I would say, in the last couple of years. We have a lot of this type of study. This is from Sweden, where they compared their pre-ERAS population to their post-ERAS after introducing an ERAS protocol. And they compare outcomes, and a lot of people have done this and published on it. They, in their relatively small series, note that ERAS improves time to first bowel movement, it decreases the risk of NG tube insertion, and it reduces the rate of readmissions, which are all important outcomes. Another trial, this is from the Southampton Group. They actually looked at the auditing and how they can improve their protocols. So again, it's a retrospective review. They introduced ERAS in January 2011, and they saw a clear benefit compared to their pre-ERAS population. So length of stay decreased. It is the UK, length of stay is longer than here. Time to Flatus wasn't really different. Ileus rate improved. The mean node yield is just an indicator of how they're doing their surgery. It was the same. But they went back then, over a year later, did a formal audit, changed some things, all minor things, but hopefully targeting marginal gains. And then they looked at their experience again, and now they've gotten their hospital stay down to 7 days median. Their time to Flatus is a little bit better. Their ileus rate is even lower, and even though they're doing more of a node dissection. So it just is an example of the process for introducing ERAS. The group at USC, Socio and colleagues, have been at the forefront of introducing and studying ERAS. They've published just recently their experience. This again is a comparison of ERAS versus a prior historic series without ERAS. 145 and 144 patients. 65% got a neobladder, which is of course quite different than a lot of the literature. And their protocol includes some of the usual things, but this is one of the only series where alvimopan is actually part of the experience. And as I mentioned, they do not use the epidural at USC. And so they're able to show the red are the ERAS patients and blue are non-ERAS. And time to Flatus has really been moved up drastically. So most patients are passing gas on day 2 and 3 instead of 4, 5, or 6. Patients are having bowel movements on day 2 or 3, again, instead of 4, 5, or 6. So huge improvement compared to the historic control. And the length of stay has also decreased dramatically, and most patients are going home on days 3 to 5, which in our environment is certainly not attainable. The only really good, or the only sizable randomized trial was just appeared in the last few weeks from China. Very interestingly, exactly the same numbers as the USC published study, 144 versus 145. But this is multiple centers, over 30 centers in China, randomizing to ERAS versus no ERAS. Some of the key differences are things like bowel prep, use of NG tube, early feeding. They do use prokinetics in the ERAS arm, but no alvimopan, and they don't use epidurals really in either arm. A good number of neobladders, so more than a third of patients had a neobladder, and interestingly, almost 3/4 or about 3/4 of patients had the surgery done laparoscopically. Their primary endpoint was the 30-day complication rate defined by the Clavien-Dindo classification, so they did a rigorous analysis of complications and found no difference, either overall or in the risk of major complications. They did find improvements in the usual things, bowel movement, regular diet, etc. And of course, the implication here is that there might be a quality of life improvement related to these factors, even though the complication rate was not better. And quality of life has been addressed by this one study. This is a German study from Munich. And they randomized 101 patients, 2-to-1 ERAS versus a regular regimen. They see improvements in, again, in a lot of the same things, including wound healing disorders, fever, thrombosis, et cetera. But they also looked at quality of life, day 3, day 7, and at discharge. Patients, of course, stay a little bit longer in Europe. And without going into any one of these in detail, you see that there is a clear improvement in quality of life by this EORTC QLQ30 questionnaire with the ERAS, which I think is very important. So in conclusion, GI complications are very common after cystectomy and can cause a lot of morbidity, prolonged hospital stays, and increased cost. ERAS protocols are effective in reducing some of these complications, reducing length of stay, and hopefully also in saving cost. And I think any hospital doing a significant number of cystectomies should be looking at introducing an ERAS protocol and engaging the multidisciplinary team to optimize outcome. Just want to acknowledge that a lot of the slides here I've borrowed from a ERAS educational program that I helped put together with a CUA committee, so Canadian Urologic Association Committee, that was funded by Merck.